Welcome everybody to our session. Thank you for coming today. I'm impressed so many of you are here. Data doesn't usually draw big crowds, and obviously this isn't a big crowd. But it's our privilege to share a little bit. I'll give the same disclaimer. I've heard a few presenters say we're not experts in this. We're a clinic that is probably struggling with data like you. But we have been asked to share a little bit of our journey, and so that's our goal. And hopefully to put that in a mission context. I don't know, numbers and math aren't always the most spiritual subjects in elementary school, but hopefully as we think through data in the context of mission, we can figure out together ways we can use it for the good of the kingdom of heaven. So my name is Jeremy Crounse. I guess I should say that to begin with. I work at SAC Clinic. I've been there for about 7 years. I'll tell you a little more about our clinic in a minute. My friend David Luong is our epidemiology analyst at the clinic. I'll introduce him also in just a minute. Okay, so what we'd like to learn together and share, something about God's love for populations. It's pretty intuitive. I'm not sure we always see that when we look at a long Excel spreadsheet. So maybe after this session, you can think about God's love when you look at a long Excel spreadsheet. Describe the value of a population health perspective, and then just our experience with working through those things. Kind of the flow of this presentation, I'll give an overview of our clinic. Then we'll talk a little bit about God's love, some population health. David's going to do most of the heavy lifting about data, and then just some conclusions from that. So just to say a couple words about SAC Health. We are a medium-sized FQHC in Southern California. Our mission statement, I usually like to highlight in any presentation we give to reflect the healing ministry and love of Jesus Christ through healthcare, education, and partnerships that empower our communities to flourish. As with all of your organizations, we try to make sure everything funnels down into this mission, including those long Excel spreadsheets. So I'm not going to spend much time on this slide, but just to say SAC came from, again, probably like most of your clinics, a free clinic that medical students were running in church basements and the streets and in the 1960s. That kind of stayed the same until the 1990s, till we got a building. Then we became an FQHC in 2015, and it's been unprecedented growth since that time. We've had a lot of work to do just keeping up with the new patients, the new providers, the new locations. So we are in a dynamic phase being a clinic. And so just some numbers, medium-sized, 11 sites, 58,000 assigned lives. And those all come from one real managed care provider, or HMO. So that does factor into this presentation. We get a lot of data from our HMO. So I don't know, I know that's not true for everybody, but that is true for us. Close to 200,000 visits a year. And then a lot of specialties and subspecialties. That doesn't really factor into what we're going to share about data, but it is a very unique piece of SAC. We have a close relationship with Loma Linda University, so we get a lot of specialists and subspecialists. It's part of our unique mission. Most of our data is in the primary care realm. Most of the quality metrics and programs focus on our quality in primary care, but that is a unique piece to our clinic. Okay, just a word on how our department is set up. So this is our quality department. I am in charge, I'm supposed to be leading. So my title is actually assistant CMO. I've seen this done every way. And so I just thought I'd share ours with you. Again, I'm not saying this is the best, but this is new. We reorganized our quality department about 1.5 years ago. That's about how long I've been working on this. David preceded me, and that's why we have success. But assistant CMO, then we have a director of quality. That's the busy person. She does most of the work. And we have a medical director of quality who helps with special projects and engaging other physician leadership. And then the director, kind of with the help of the others, manages these teams. So the population health team is an important team really to highlight in this presentation because they're really the ones that reach out to patients. So they are the ones intimately involved with the Excel spreadsheet and the data that David finds for us. And we're kind of putting a target on the wall, and they're shooting for it. They're contacting patients. We have 9 care coordinators in our population health team. It is supervised by an RN, and even the supervision has been developed. The team has grown a little bit. I'm not going to say much about enhanced care management because it would probably be a presentation all of its own, but this is a program that's paid for by Medi-Cal. It's a great program for California residents. Basically, patients, members who are highly complex, severe mental illness, homeless, recent incarceration, kind of your clinic, right? Those that really need help can be enrolled into this program, and the program pays our clinic to take care of them. So they cover all of our costs for a 4-person multidisciplinary team to manage those patients. So it's a lot of population. It is the most intensive population health. It's been a huge bonus to our patients as well as our clinic as we try to manage these complex patients. And then there's David as our data guy. So we have an IT department. Our IT department gets us data. It has been invaluable to have somebody who understands us in the quality department as well as a bit of background in healthcare and public health who can bridge that conversation between what we need and the data that we have. Okay, so on to God's love. We should probably just spend the rest of the session here, but we said we'd talk about data. Just want to point out in the Bible how the Bible highlights that God loves big numbers of people and little numbers of people, right? So it says, for God so loved the world, that would include all of this planet, past, present, and future. So we know that number is in the billions and 8 billion in the present. But then he's not only transcendent and loving all and knowing all, he's also immanent and knows all of the details of our lives. So it is kind of like that Excel spreadsheet, except that it's got an infinite number of variables on it. But when I just think about the amount of data that God processes, it's overwhelming. I can't, but he does. And I think as we're dealing with data and processing it, there is a bit of the divine in that. It's kind of sacred when you think about it, because we're not just talking about numbers, we're talking about people's lives. So since this is a numbers, we're going to talk about the use of numbers, I just wanted to throw a number out there for you today. When we say that God is great, we can't comprehend that, right? So since we're a data crowd, just wanted to give you a few numbers about the cosmos. This is what astronomers believe today. I Googled it, so I know it's true. The number of galaxies in our universe, 2 trillion. The number of stars in a galaxy, 100 billion. So you put those together, it's some number that I don't remember, or 200 billion trillion. So that's the number I just want to leave with you, like 200 billion trillion suns in our universe that we know or that we think of. When we think about God being a great God, he is so much greater than we can even conceive. And really, I would say this means that we really don't have any big problems, right? And this goes beyond the data talk. Whatever problems your clinic has, or even you as an individual, it's not a big problem. We have a God that manages 200 billion trillion stars. Don't let those problems get you down. Okay, a little more specifically now, but the Bible does give lots of examples of God caring for populations. He cared about Nineveh, 120,000 people. You couldn't tell their right hand from their left. It's about twice as much as our population at SAC. He also cares about hungry people, for those of you struggling with SDOH. Anybody struggling with SDOH? Is that a California thing? It is a California thing. Well, anyway, Z59.41, you probably already memorized that. But 2 stories right back to back. As if one story wasn't enough to make the point, it happened twice, back to back in Matthew. About Jesus feeding these hungry people. Large crowds. He saw these large crowds, and he had compassion. And he took what the disciples had, or what they found, and took care of their need. Okay, so maybe just to spend a minute on this population health, I was going to ask this at the beginning. How many doctors are here? I'm a doctor. Okay, so there's some doctors here. How many data people, non-doctor data people are here? Okay, great. Okay, so nice mix. Yeah, so I think as doctors, we get trained in clinical medicine, right? Like, we take care of the patient in front of us. And we spend a long time, 20 plus years, learning how to do that right. We don't get a whole lot of training on, how to take care of the population, unless you do some public health or maybe preventive medicine. But I think it's good for every physician or physician leader, or really any leader in healthcare, to understand the value of seeing the population. And again, I am always refocusing this, because you, on one hand, have the doctors who see the patient in front of them, who's maybe sick and they're doing their best to care for. And then you have the non-doctors who see an Excel spreadsheet that has no body, no heart, no soul. But I think really what we need to do is merge those two. And so I always, and this presentation and slide is for me more than anything, but just to read the verse, when Jesus saw the crowds, he had compassion on them because they were harassed and helpless, like sheep without a shepherd. I think it's important for us to always remind ourselves that we care for people, not for numbers. Even if an Excel spreadsheet is all we ever see, like we should pray over that Excel spreadsheet because the decisions we make from that data will affect people's lives. This is a picture of my late wife, Shalina, and our 3 children. It had been our life's dream to work in Malawi as missionaries, and we got to do that for 3.5 years. When we came back to have the little guy, Caleb, she was diagnosed with stage 4 breast cancer a week after he was born. And that kind of changed our life plans. We went from being missionaries to being patients. And that led to about 6.5 years of treatment for metastatic breast cancer, change in career, change in everything. And she passed away last January. And she was young when she was diagnosed, so I'm going to talk about cancer screening. Cancer screening wouldn't have changed what happened in her story. But her story for me has highlighted the reality that every number that we think of is a person, right? It's somebody who has relationships, attachments, who makes a difference in other people's lives. And so when we talk about these things that can help people, like cancer screenings or others, we are really affecting families, we're affecting people, we're affecting communities, and it really is a sacred work. Okay, so a little more detail on population health. I like this slide. This is my son, Jedediah. I did not know there was another Jedediah in the friendly CCHF family, but Andrew Brower has one now too. But, you know, for some reason last year I decided we needed to hand hew a log. Has anybody ever hand hewed a log? All right. So, anybody ever wanted to? Okay, I'll go real quick on this slide. So, you take a round log and you want it to be square, but it doesn't happen in one whack. It's an iterative process. You're peeling off bark, taking off the round side here and there and there. And then, if you ever meet somebody that wants to hand hew a log, tell them to get a broad axe, that tool, because that tool is what really makes a hand-hewn log square. So it takes some energy, some perspiration, a process, and it takes a good tool. So hopefully we'll talk about all those in this presentation. So the iterative process. This is a little bit of data for you. Again, David's going to talk more about that. But you know, how do we do this process in our clinic? This is one of our quality measures, controlling blood pressure, and kind of our recorded performance over the last 4 years. You can see 2020 was really bad. I mean, it was COVID. It was bad for everything. But it wasn't that bad. I can tell you, more than 14% of our patients had a blood pressure less than 140/90. What was really bad about 2020? Our data. Our data was really bad. So we used that year to sort out the bugs. And you can see the next year, we improved by 32%, really by improving our coding for that one. So coding in the data world is very important. Figuring out what the problems are in the bugs can substantially improve your performance as it's recorded. And then, you know, you can see through the other years what we started some text messaging, we started rechecking blood pressures, we started population health outreach, and we're still not at our goal. So we have to think of more things. But this is kind of the approach to population health, which again is probably not anything new to you. But what does it do? So we're working on this, we're trying to get our right tools, see the data, interventions, pop health. Well, it actually does a lot. This is a trial, it's kind of old now, it's from 2009. But you can see here, if you just look along this all trials line, the relative risk for coronary heart disease, and I should say this is with a 10 millimeter decrease in systolic blood pressure. Relative risk, 0.78. So you decrease the risk of a coronary event by 22% by decreasing the systolic blood pressure by 10 millimeters of mercury. Even more significant for stroke, a relative risk of 0.59. So 41% decreased risk of stroke. That's where this data and all these efforts come down to the individual. Well, what does that mean in a population? Those numbers I just told you, 41%, 22%. But if we assume a 50% population attributable risk, which I'm not going to elaborate on, but basically saying 50% of the population gets strokes from hypertension, you would avoid 175,000 strokes. That's a lot. That's a lot of mothers, grandfathers, and prevent about 30,000 stroke-related deaths. That's in the US population. But you can see there the effect, you know, It's going from the Excel spreadsheet where you know these things to changing the outcomes for the patients. I couldn't help myself. I had to have one slide that had some colorful vegetables and fruits on it. How can you get there to the 10 millimeter decrease in the population? Well, some things lend themselves easier to a population, some don't. Medications, that's going to be mostly the docs, right? We have to talk to patients about those. But 20 pounds of weight loss, you can do that without a doctor. I can tell you might do it better without a doctor. A whole food, plant-based diet, again, or a DASH diet, those have been shown to really significantly change hypertension. And you can get half that much with regular exercise, decreased alcohol, restricting sodium, and a high potassium diet. So lots of population health friendly things that could be done and have been tried and done in different situations. Okay, now just to switch from hypertension to cancer, I also could not help myself, and I had to include one slide about the world. You can see here the vast difference when we talk about numbers across the world. The US is in lighter green. That's, I think, about 2 deaths per 100,000 women years. If you shift over to the middle and see Malawi there, where we were for 3.5 years, you see a high burden of cervical cancer, about 10 times as high as the United States. And there's lots of reasons for that. Again, it's not really what I'm trying to share in this presentation. But once you identify the areas that are hurting the most, you can think about how to address them. And I guess that's the point of the slide. So in the United States, how have we done? We've done pretty good because we got a pretty good tool. Right? The United States got a good tool for cervical cancer screening in the pap smear in the 1960s. And we have dramatically decreased the rate of death from cervical cancer. Unfortunately, we've kind of plateaued. And in reality, I think all of the physicians in the room can agree that no one should really die from cervical cancer. This is a preventable cancer. And so we still have more work to do. Again, more numbers. Just wanted to share. These are not new numbers to most of you, but the burden of cancer is high when we talk about cancer screenings. And this is a big part of what we do in our quality department with our data. It's not insignificant, you know. And again, just to highlight the point, this is for 2023. My wife died in 2023. 43,000 women died in 2023, and they all filled a similar place in the world. And so when you think about that, you know, you see behind all these numbers the reality. Okay, I'm just going to take a minute on this slide. It's really busy. It's a bad slide and maybe the most interesting slide in the presentation. I don't know. But just to dwell on cancer a little bit. So any cancer for a man, and maybe we'll just go to the death column there. So there's a 1 in 5 chance that any man will die from cancer. 1 in 6 for women. And again, these numbers are non-skin cancer, basically non-basal cell or squamous cell cancers. So breast cancer, you can see 1 in 39 women will die from breast cancer. But then the next one is kind of where it gets a little more real for us. When we screen, what does that do? Okay, we screen for breast cancer with mammograms. Unfortunately, and I don't want to make anyone disillusioned here, mammograms are not great screening. That's not because I'm saying you shouldn't do them or you should do them. I think you should just understand they're not the best screening tool. If you look down here to like the pap smear, that's good. Like pap smears really work, 80 to 90% plus. Mammograms, we just don't have a great tool. And you know, the best case scenario is like, the best illustration is prostate cancer. Like we don't have a tool that works for prostate cancer at all. But anyway, we do save some lives screening for breast cancer. And if we screened everybody, how many lives would we save? 2,800 in America. How many would we overdiagnose? That's not an insignificant number either. I'll talk about overdiagnosis in just a second. Colon cancer. Higher number of lives that could be saved through screening, about 50 to 60%, so better screening and a more aggressive disease. How many people would be saved if we screened everybody? About 35,000. So if you're thinking about where is the biggest bang for the buck in cancer screening, it's in colon cancer screening. That's the reality. I did not know that until I put this presentation together. And then the rate of overdiagnosis is low. Cervical cancer screening is good. Fortunately, the prevalence is low, and so you're not going to save as many lives, but up to 6,800 if we were to screen everybody. Any questions on this slide? I know it's busy and confusing. Yes?
So as you look at that, don't you also have to look at the cost of screening as a factor in that?
Well, I didn't include cost here, but yes, if you wanted to see the financial impact on the healthcare system, you would.
I mean, because yes, we want to save 35,000 lives, and I know it's not that expensive, but let's say a colon screening costs $5,000 to do, and a breast cancer screening costs $500.
Yeah. Yeah.
Cost savings ratio of lives, that would be the same. I realize that's not actual numbers.
Right. No, I mean, cost is definitely an issue, and we do have these conversations in America as if these don't cost anything, which they do. Fortunately, we haven't really had to ration too much, but that's a good point. I think the healthcare system response to that would be is if we diagnose a cancer earlier on, we will save money than diagnosing it later on or too far. Did I see another hand over here? No. Okay. So just, I thought this was a nice slide on breast cancer screening. Again, so if we were to screen 1,000 women, this is from the UK. So again, a healthcare system that cares about cost, right? Probably more than we do as an overall system, and is fairly mature, I think, in their evaluation. You can see the numbers without screening and with screening. The bottom line, with screening, you would save 5 of those 1,000. It would be at a cost of overdiagnosis. 17 would be overdiagnosed with a cancer that would never cause them problems. And there would be a lot of procedures. We know that, those of us who function clinically. So I am not in any way trying to talk anyone out of breast cancer screening. I do think it's a conversation you should have with patients when you have the opportunity, because it's not perfect screening. Even though the USPSTF is revising their cancer screening recommendation, you're probably aware of that. So we will, in effect, be doing more. I just think it's important to know what we expect from the tool, right? Like, not every tool is created the same. Okay, so a little bit of data. How is SAC doing in these cancer screenings? I think the bottom line is we haven't made it back to pre-COVID levels yet. So COVID was a little bit rough on the population health front. And you can see as far as breast cancer screening, we were 71%, we're 66 now. Similarly, cervical cancer screening. Fortunately, the trend is starting to slowly turn upward on those. You see colorectal cancer screening, it's just terrible. So that's on the top of our list for this year to try and address and fix. But, you know, in this conversation, I think every part is important, right? The data is important because then you know where to work, and David's going to tell you how we got this in a second. And then the caring for people is the reason we care and do it. Okay, this is a picture, a deep field picture from the James Webb Telescope. Basically, this telescope orbits in space. If you think about taking a grain of rice, holding it at arm's length, that is the amount of the sky that this is looking at. So it's looking at basically a rice grain size of the sky at arm's length. And when they took the picture with the telescope, you know, it was kind of a dark spot in the sky. This is what they saw, you know, and it's like galaxy, 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 and you know, just the universe is just too big for us to comprehend. And that is the end of my part. And just because this is a dry data speech, I wrote a song. I've never written a song for a data speech before, so we'll see how it goes. 58,000 lives, all assigned. Fathers, mothers, sisters, brothers, searching for the light, suffering in the night, each one looking for the answer. How can I How can you know each name? How can we be the body of Christ, each one healing in his name? 8 billion in the world, old and young, boys and girls, the blood-bought ransom of our Savior. Some have seen, some have heard, most still waiting for his word. How can I love these people? How can you know each name? How can we be the body of Christ, each one healing in his name? 8 billion years of light, sparkling in the night, the cosmos are vast beyond measure, shining for the King who shines in everything and gives them to us for our pleasure. How can I love these people? How can you know each name? How can we be the clinic of Christ, each one healing in his name? All right, it's my pleasure now to introduce David Luong. He is our... That was hard enough. I cannot tell you how hard it is to make a video. We tried a video recording of this, and it was awful. So it's my privilege to introduce David Luong. So I work with David a lot, and I cannot tell you the value that he's brought to our quality department. I mean, I came into the quality department, he was already there. But he's going to share a little more of the nuts and bolts about how we get the data and how we use it.
Thank you so much, Dr. Crounse, for showing us the importance of population health and for the amazing song. We really enjoyed that. And so now I'm going to talk about data and how we get the data, how we use the data. To begin, data sources. We have 2 main data sources. One is our electronic medical record, EMR, and 2 is our managed care plan, MCP. For EMR, we have Epic. Our MCP, we have IHP Provider Portal. IHP stands for the England Empire Health Plan. So why do we need 2 different data sources? Because one, our EMR, does not have information on our assigned population. We don't have data on the patient populations that are assigned to us, no P4P measure, status, etc. And for our managed care plan, we don't have encounter data. So we don't have information on the visits, the PCP of the patients, stuff like that, or the upcoming visit. So we need both information to determine which population to outreach and to bring them in for visits. So here is it's our MCP data. What kind of data source what kind of data file can we get from our MCP? 1 is report card, 2 assigned lives, and 3 measure roster. Report card contains information on our performance on our clinical quality measures. Assigned lives contain all of our assigned patients, like 58,000 patients who are assigned to SAC. Measure rosters, which clinical measure are they part of, if they meet the measure, if they did not meet the measure. We mainly use this for outreach population, track our P4P performance, and IHP population. We'll talk more in terms of how we track it later on. But now let's get into our EMR data. What kind of data can we get in our EMR? we mainly get our encounter level data and health maintenance and care gap. As I mentioned before, encounters, like if they have a PCP, who is their visit provider, and their visit date, etc. Health maintenance and care gaps. On the picture on the right, you see an example of a patient's care gaps. Care gaps contain information on what are the patient due for, all the screenings, the tests that they are required for, things that are due or almost due. This also help us with outreach populations and data validation. We'll get to data validation toward the end. So how do we really use the data? So here at SAC, we use Tableau. Tableau is an interactive data visualization software. Are we all aware of Tableau? How many people know of Tableau here? Okay, perfect. We have a good Tableau view. So it helps us create different interactive dashboard and visualizations. It can handle very large volume of data and also perform data analysis as well. So let's get to this table here. It's kind of like show us how we get different Tableau dashboard. To the right, you can see we have 3 different types of Tableau dashboard. One is our overall P4P performance. 2 is population demographic, and then 3 is PCP and department performance. We can get to each of the dashboard, and we show you like how we get there to which data source. So first, let's look at our overall P4P performance. The data source comes from our MCP provider portal. We get the report cards, and then we convert that into our Tableau dashboard. The reason we need a Tableau dashboard for this is because the report card only shows us a snapshot of our performance at the current time. It just gives like, oh, how we're doing for this measures, are we meeting the tier goals or not? But we need Tableau so we can compare the data. So in this example here, we compared our 2023 data in red and then 2022 final data in blue. As you can see with this Tableau, kind of give us like a performance, like are we doing better than last year? Do we need improvement in which measure? At the bottom, you can see it shows like the % improvement for each measure compared to last year. And the bar on top indicate the goal that we have to reach. That is tier 4 goal. I didn't mention, but IHP had 4 tiers. The higher the tier, the better we improve, and the more financial incentive we receive for our health plan. For simplicity, we only display tier 4 for this. But in Tableau, we're able to select whichever tier, and it's more interactive in Tableau. We can look at more specific with this dashboard as well. Instead of looking at all the measures, we can just focus on one measure. In this example, we have immunization for our adolescent combo 2. We're comparing month over month to see our trend monthly as well. Are we improving each month? As you can see, from April all the way to December 31st, we reached all the way to our goal at this point. Another way we can compare this dashboard is year over year as well. We'll compare like 2019 data all the way to 2023. Next, we're moving on to our population demographic dashboard. So the data source for this one also comes from our MCP provider portal, but this one requires 2 different files. It has the assigned roster, 58,000 patients, and also measure roster, which measure they belong to, so we can track their population demographics. So here, just quickly, it's just an age distribution of all 58,000 assigned patients. In Tableau, we can select any age range we want, and it'll give us the exact number of how many patients fall in which age group. We can also have age category as well. In this example here, we have 0 to 12, which account for 30% of our populations, 13 to 18, 12% of our population, and so on. Another demographic data we have is gender. We have 58% women populations and only 43.5% male populations in our clinic. As Dr. Crounse mentions, we have multiple clinics. We have 58,000 total, but in order for us to, this Tableau dashboard allows us to see our distribution of patients across different clinics. As you can see, 31,000 of our patients are assigned to San Bernardino locations, and then around 8,000 Norton, and so on. Frazee is a much smaller clinic, so we only have under 500 patients. Another cool thing with Tableau is that we can see geographic data as well. We can see the patients' density by different city. This is Southern California. The majority of our patients are in San Bernardino County. Lastly, we're talking about our PCP and department P4P performance. In order to have this dashboard, we require data from our MCP as well as Epic data to get like patient and county data on like PCP and stuff like that, and as well as measure roster from the IHP provider portal. So once we combine the two, we have individual performance for any provider we want here at SAC. So in Tableau, we can just select the provider, which provider we want to see their individual scores, or have this table for all of them. It shows all the measures. The red, it means they did not meet the tier goal. Blue, or yeah, like kind of blue, it means they met the goal. Which measure they meeting, which measure they did not meeting. At the bottom, you can see the populations of patients for each of the measures, like how many patients are up in panel to this individual PCP. Finally, we can also compare by department as well. Here at SAC, we have multiple departments. We can select any measure, and we can see which department is performing best in the department, which department is performing the lowest in the measure. And this kind of help us determine where to improve, and how to learn from the high performer as well. The line indicate the tier goal. So red, it means they did not meet the tier goal. Blue means they met the tier goal. Just quickly here, this table kind of demonstrate how Tableau is pulling data for our MCP as well as Epic data. So the top data file is a roster from our MCP. The bottom file contains Epic data. So it combines the two, and we're asking Tableau to pull this data point in Epic. So this one, we're looking at the combo 10 measure. So it's pulling the date of vaccination for each of this measure. Will give us the roster of patients, and then the date that they receive each vaccine. This kind of help us target the patient, because we can determine which patients did not receive which vaccine, because they don't have a date which indicate they did not receive that vaccine. We can call and outreach. One example that we have is HPV. We identify patients who got the first dose of HPV, but they're missing the second dose. So we call and outreach those patients to bring them in for a second dose. Data validation is very important. There's two different methods that we validate data. It's supplemental data and historical data. We won't spend too much time talking about the two, but the main difference is that supplemental data is on a broader scale, impacting like the majority of patients, the top population in that clinical quality measures. Historical data, it's just a few patients where we can submit data directly to IHP. As you can see, this is a timeline for IHP supplemental data. Important date here is like July 1st, 2023. We communicate with our health plan all the way until the end of December. It takes 6 months to make sure that our health plan get the most accurate and updated data as well. So yeah, this is all the data, tables and graph I have to share with everyone. Thank you so much for listening. And we'll have Dr. Crounse come back and talk more about population health.
Thank you, David. So just to wrap things up, I just have 3 slides left. When most people think about data in healthcare, they think about money, I think. And so that's why we tried to intentionally start this with people, because certainly as a healthcare with a mission, this is all about people. I didn't think we should completely leave it out. And so, how does this all come together? Well, hopefully this all comes together with taking better care of populations. We know that taking better care of populations saves all of us money. It saves the system money. But more than that, it saves people's lives. It saves them from disabilities in certain ways. So there's lots of incentives to do better on these quality metrics. So IHP is our HMO. So just to make sure you got that, we have one really managed care provider, it's IHP. They have assigned us 58,000 lives. So they give us a lot of data. So if you don't have that in your life, you're gonna be missing one of your major data sets that David just told you that we have. It is a blessing to our clinic to get data from them. We do check that data and we supplement it with our EMR, which is kind of what David was explaining. But from IHP, there's a program called P4P, and they pay us from this program. And you can see pre-COVID, and all of these 39 quality metrics distill into one score. So this global quality P4P score is what determines how much our clinic gets paid as an incentive. I'm guessing many of you have similar incentive programs. So you can see in 2019, we were doing pretty good. Again, COVID hit, and we tanked, and we've been struggling to get back. And had some progress last year, and 2023 is looking better. It's not done yet. We hope that continues to go up. And you can kind of see the bar graph there. So what does that mean? Hopefully, well, we know that in these areas it means people are healthier, and healthcare is not costing as much. So two important things for our communities and our system. But it also means, because it's a P4P program, that our clinic gets paid more. And I'm not going to ignore that, because this is a work that should more than pay for itself in the current economy. Now, that may not be true for every system, because some systems may not have a managed care provider that even has a P4P program. You may not get rewarded for quality metrics by anybody. I don't know. I know every clinic is set up differently. In our system, this is definitely paid for itself. We did invest a year and a half ago into more support for our quality department, our population health department, and the P4P program, and it is certainly more than paid off. And I'll just tell you, we don't know for 2023 yet. We'll see where we end up, but from 2021 to 2022, the difference in our payment over the 12-month period would be more than $2 million for our clinic. So you can cover a fair amount of costs with that kind of incentive that again is going to only become more and more common in our healthcare system as far as I see it. So I basically just talked through this, but when we give higher quality care, we save money, we save lives. But the payers save money, right? The insurers have this money, they save it, and so they're smart, and they say, well, why don't we just pay you on the front end to incentivize you to do this, so we save money on the back end. And that leads to incentive programs like P4P programs. So, and I think we know the trajectory of healthcare. We're coming from a system where you saw a patient, you wrote a note, you got paid. And every patient you saw, you could, there are some exceptions, but basically, you saw the patient, you got paid. That's the fee-for-service approach that we're coming from in medicine. That's still kind of our main model of care in our system, but now there's this sprinkling of P4P where there's an incentive towards quality. And if we perform perfectly in our P4P program, that could be 10% of our budget, which is not insignificant, over $10 million for our clinic. So we got about half of that for our clinic, but you can see the payer is shifting from just paying you for taking care of the patient to paying you for that, and then some additional. And in California, they've been pretty clear. They're doing that intentionally to shift the whole system towards a quality system, where one day we might be getting 40, 50% of what we get paid based on our quality score, and one day it might be everything. That we have to show that we are doing good care for this population. As long as we show that and meet certain thresholds, we will get paid, whether or not they see the doctor. And so as a healthcare system, that gives a whole lot of flexibility, and as a kind of a population health guy, I love that flexibility, because you can think about offloading the docs and preventing the stress and burnout that comes with just the rapid pace of healthcare. You can hire the multidisciplinary team to do this. So in our world, we call that APM. I don't know if anybody's here from Oregon, but I think Oregon already has APM, is my understanding. But we see our clinic going there in 3 to 5 years, where we will not really be reimbursed on a fee-for-service model, but we will be reimbursed for the outcomes of our population. I'm excited about that. Everybody else is scared to death. Okay, so where does this land us all? Kind of hopefully back where we started. Everything we talked about today, all of the tools that we have to work with this data, all of the outreach possibilities that we can think of as a clinic, all the ways we manage this population. It's just another expression of God's love for our world and these populations. We know He loves them. We know that the decisions we make change lives. It's not as heroic as doing surgery, because they'll never know who was working on it. But it changes lives just as much as the interventional practices in healthcare that we do. And with that, we will conclude our talk. Any